damage or liver damage or something else are minimized. There are also negatives of inhaled antibiotics, and many of them are practical. Most people know that inhaling antibiotic tends to be very irritating, causes a lot of cough, it's kind of unpleasant, the taste is unpleasant. Some of the inhaled antibiotics take a long time to deliver, and so it's kind of a tough part of therapy as compared to just taking a pill twice a day, but very, very useful. And the first commercial inhaled antibiotic that we used many years ago and still use is Toby, or inhaled tobramycin, and that has been very effective. And then along maybe 3 or 4 years ago or something came Caistin, or Aztreonam, and that allowed us, it's another alternative to Toby. So, for example, if the particular bacteria in your lungs are no longer responsive to tobramycin, they might be responsive to Caistin. So that is, and those are basically the 2 inhaled antibiotics that we have. But we're always looking for different antibiotics, whether oral, IV, or inhaled. And there's a tremendous amount of research, and we, from what I understand, are anticipating new inhaled antibiotics on the market in the very near future. And some of these are listed. A lot of people in this room are extremely familiar, more familiar than they would like to be, with Cipro. It's kind of a standby for treating Pseudomonas, which is a common organism in the lungs of people who have cystic fibrosis. And scientists are working on inhaled forms of Cipro and a cousin drug, Levaquin. Some of our patients have MRSA or MRSA in their lungs, and that's part of their recurrent infections. And there are some oral antibiotics and some IV antibiotics available, but so far no inhaled antibiotic is available to treat MRSA. And yet there will be soon, we hope, inhaled vancomycin, and then various others. So inhaled antibiotics, again, kind of as compared to the new drugs, are not exciting. They're just a variation on the theme, but they're extremely effective and extremely useful for us. So watch for new inhaled antibiotics. Okay, now, trying to look for what slide to bring. I'm just going to skip that. The last thing I want to talk about before we get into the brand new drugs is the various kinds of airway clearance, physical airway clearance. And as everybody knows, our team is extremely enthusiastic about airway clearance vests of various sorts. We really appreciate the vendors being here today. And there are a few different brands that are available. There's one new vest that we've just been introduced to called the Aflo vest, which has a little bit, actually a fair amount different technology. And we get asked about this a lot in clinic, and we didn't really know much about it until very recently we were introduced to it. And it's the nice thing about that vest is portability. People it's not tied up to a big machine, and people can kind of move around, and has a very flexible use. And so that's something that you may start to see as well. So, the main thing, and there's an old kind of saying about chest physical therapy going way back to the days of when people just did manual physical therapy and vests didn't exist, and then we went with various kinds of fluttering kinds of inhaled device, the Flutter device and Acapella and various others. And all of these different kinds, and then the vest came along. So all of these different kinds of physical airway clearance or chest physical therapy are effective. They've been proven to be effective, and they're very important. They're also kind of a hassle in everybody's life. People don't like to do it, but the people who really buy onto it and can somehow find a way to discipline themselves, just like flossing your teeth, really benefit from it. And the most important thing, because these are all effective and have been proven to be effective, is whatever is easiest to use and get into your daily routine, we're going to encourage you to do. And some people prefer different ones. So that is another thing that we will be looking for, is the possibility of a new vest for some patients. Now, the new medications. Okay, forget all this. We're going to have a nice talk later today on Pseudomonas. I won't say anything about Pseudomonas. now we're talking not about inflammation or infection or so on, but actually somehow or another fixing what the gene does wrong inside the cell. And then that's where we went through all that stuff. Okay, so back to this one. The first drug that came on the market, Rebecca already mentioned it, was Kalydeco. It's been out for a little bit over 3 years now, and that has to do with this mutation here, where the building looks good, and therefore it's allowed to go up here, but it doesn't transport flora because it's closed in a sense. And so a particular drug or chemical was identified as being one, a very complicated and fascinating process, for one that might fix this, and was put into double-blind studies that were completed and presented to the FDA a little bit over 3 years ago, and Kalydeco came on the market. Kalydeco, that particular study was for people who had that mutation, and it was studied in patients who were 6 years old and older, and was released. And we've got 2 patients in our clinic we were able to get on this drug at the time that it was released. We were cheating a little bit. They were about 4.5 years old, and of course they're now over 6. And this is really an amazing drug. Kalydeco, the old-fashioned and still sort of in some ways gold standard way of diagnosing cystic fibrosis is with the sweat test. And if you have this particular mutation and you take Kalydeco on a regular basis, it actually makes your sweat test normal, and inside the body, inside the lungs, it changes, it opens up that chloride channel, changes the secretions, and has a tremendous effect on the health, positively, of patients who have that gene mutation. The problem with Kalydeco is that only about 5% of CF patients have that mutation. So, ongoing research was already going on as the Kalydeco research was going on for drugs that were effective for people with other gene mutations, and particularly the most common gene mutation, which is the Delta F508. In terms of Kalydeco, though, specifically, there is another class of mutation which I mentioned very briefly. This one, and it is kind of similar. It's different in very subtle ways, which, quite frankly, I would not be able to explain to you or to myself. But it's similar, but slightly different. And the question is, would Kalydeco work for this as well? And we were lucky not only to get 2 of our 4.5-year-olds on Kalydeco when it first came out 3+ years ago, but we also had one patient who had this mutation that I just wrote a prescription for, even though we weren't supposed to because they didn't have the right mutation. And the insurance company said, okay, and I think they weren't really tuned in to the implications of what this might mean in terms of expense. And that patient was placed on this drug and had tremendous benefit. And right around that time, studies were also, scientific studies were started up to see if what we did in an unscientific way would be effective. And the studies are done, presented to the FDA, and have been approved. So people who have this particular mutation or similar mutations can now get this drug. What's upcoming, we hope, in the very near future, within the next month or so, and somebody correct me if I'm wrong, I think about within the next month, is that the Kalydeco for the 551D, this one, the original one, the studies, remember I said the original studies were 6 and over, the studies for children 2 and over, 2 to 6, were completed, presented to the FDA, and the FDA will probably rule on it within about the next month or so. And the presumption, because Kalydeco has been such a success both in terms of effectiveness and safety, lack of side effects, is that that will also be approved. So we're looking excitedly forward to that. A little bit further off, but not very much further off, is the studies involving Delta F508, because most of our patients have this genetic mutation. And this is a more complicated situation, right? Because not only is the building degraded, so you have to come up with a medication that will allow the building not to be degraded and be built up here And then, if it doesn't function very well, which it doesn't, then you have to have something that opens it up. And so what was done is they came up with a drug, the Vertex company called VX-809, that does the first of those things. And then they said, well, gosh, once it gets up here, will Kalydeco open it up just the way Kalydeco opens this up? And the answer is yes, it does. And so that is actually a combination of two medications that are taken orally twice a day. That study is completed. We were involved in the multi-center study. The data has been presented to the FDA, and we're hoping for a ruling on that data, on that drug, early this summer. So that's another very exciting thing to look forward to. Okay, I'm going to say this. There are all sorts of other kinds of these. To some extent, these are the medications that we hope and are using for our patients on a day-to-day basis and are making a difference. But these are only some of them. These are, in some ways, you can think of these as almost examples. And there may be other drugs which will be even more effective. There's one that's, and I've totally lost myself on my slides now, so forget about it. But there's another, the one that's being presented to the FDA right now, combination of Kalydeco plus VX-809, that's one set of drugs, and the data look pretty good. Quite frankly, it didn't blow people away. It looks like an effective drug, but not an amazingly effective set of drugs. But there's another drug instead of VX-809 called VX-661, which is now being studied, and it's not ready to present to the FDA. The studies are just kind of ratcheting up. But the initial pilot studies suggest that the 661 is more effective than the 809. So the way I see it, and I am not, it's just my guess, educated guess, but that it may be that, assuming everything goes well, with the current drugs that will be out this summer, we hope, fingers crossed, will be something that we'll be using in our patients for a few years or a couple of years or something like that. And it may be substituted by another drug that then comes on the market that's even better. So elevating ourselves. And all of these things we're doing, you go back to those initial graphs that I showed at the start of this talk, and the prognosis just keeps improving. So it's extremely exciting. One of the things that you're going to see on the internet and that I find very fascinating and waiting to see what's going to happen is one of the many drugs that's being talked about is something called Cystagone. And I don't know if there's anybody, I know somebody in this room has heard about it because they told me about it. But anybody hear of Cystagone? Okay, so, and this is not an endorsement at all. I have to be very careful about how I say this. But there is a medication called Cystagone that has been out for many, many years. I don't remember a couple decades or something like that. That is being used in treatment of a totally different disease. It's a rare genetic disease, totally different from CF, and it causes organ damage to various organs. That medication has been out for a long time. It's very effective for that condition. Some cystic fibrosis centers and scientists in Europe, particularly Italy, and I don't know the whole story, stumbled onto, or reasoned, maybe they didn't stumble, into a line of thinking that Cystagone might be effective in some way similar to what some of these drugs have done in terms of changing the, back to that picture, changing what happens to that chloride channel so that it can get where it needs to be and work the way it needs to work. And there was an initial study, I guess we could call it maybe a pilot study, but a whole set of studies in the test tube, very small number of humans, and then in experimental animals, and then a slightly larger number of humans, patients who have cystic fibrosis, that makes Cystagone look like potentially a very exciting other drug that is basically similar to these kinds of drugs. by the way, I don't think I said it, but this whole class of drugs I've been talking about are called gene modifiers. So there are things we can't yet quite successfully change the gene itself, which is ultimately what will cure cystic fibrosis. But the next best thing is you can't change the gene, you change what the gene does inside the cell. And that's what I've been talking about for the last, I don't know, probably too long. So all sorts of examples. And the nice thing is if one drug comes along that looks very promising, let's say 661, and by the time they get to the end of the study, either it doesn't work as well as we thought, or maybe it works great but it has too many side effects, it's not going to be safe to use, a whole bunch of other drugs there as well. And it's just tremendously exciting. And as we already heard this morning, it's almost, in some ways, it's a real dilemma because we have almost more drugs and treatment approaches and so on than we have patients to try them on to see if they're going to work. And that's a dilemma, but it's a pretty cool dilemma. I mean, it's much better than the opposite. It's like having all those patients and no new ideas even coming down the pipe that we can try to see if they're even be effective. So, I won't say anything about I will. I'll say about gene therapy. The ultimate thing is to fix the gene itself. And I know very, very little about gene therapy and the ins and outs of it, but the summary, which I always tell patients if they ask me about it, is that in some very real senses, gene therapy has already been done in cystic fibrosis. And I specifically remember when the gene was discovered in 1989, I happened to be giving a talk to a group of family practitioners a couple of weeks after that, and it was about cystic fibrosis. And I brought in there was a little newspaper article from the Spokesman Review that said now that the CF gene has been discovered, there will be gene therapy within the next year. And I kind of presented that and was laughing about it. I said, well, that's, they're kidding us. It's going to take decades to figure out how to do it. Well, lo and behold, they actually, in one very real sense, gene therapy, successful gene therapy was done in cystic fibrosis within the next year or so. But they then started to run into all sorts of problems in terms of being able to, you can do it in a test tube, you can actually do it in a human being through either a bronchoscope or even a nebulizer. You can nebulize in the appropriate gene and fix the gene in the body, in the bronchial tube, and they work. The chloride channels work. But that's a fix for only 2 or 3 months, and then you have to do it again. And the next time around, the body, that good old inflammatory process I was talking about, the inflammation says, hey, this is not something that should be coming into our lungs. This is something that could harm us, and it rejects it. And therefore, the problem in gene therapy ever since then, ever since basically, I guess, 1990, has been how do we get some way to get the gene in there over and over and over again without the body rejecting it. And that's where the research is, and the research is coming along, but I have no idea when it's going to be, when the puzzle is going to be solved. I also wanted to remember we've had some questions. By the way, I kind of threw at the gene modifier drugs and stuff. Any question about that? And I just have a couple more things to mention. Okay. All right. Stem cells. We've had a question about stem cells. And as a matter of fact, I'd never heard anything about this until a question came up. I've heard stem cells. But in cystic fibrosis, until a couple months ago, one of our patients asked, and then we said, I don't know, I went on the internet, and I couldn't really find anything about it, and subsequently, apparently there's a lot of interest in this, and the National Cystic Fibrosis Foundation has communicated with all of the clinics and given us some information in their opinion. Apparently, stem cells are all the buzz for treating cancer and all kinds of different diseases, and have in I guess limited ways very successful in certain diseases. But there are some people, and I guess even in other countries, and I'm not sure about if anybody's fooling around in the United States with this, but who are offering successful stem cell therapy in which you basically can, in one way or another, get stem cells that will supposedly replace damaged lung cells. So instead, we're not talking about changing the gene, we're talking about lung damage and replacing damaged lungs, so that ultimately, for example, if you have severely damaged lungs, to date, the only option we have for very, very severely damaged lungs is lung transplant, which is a whole other subject that we could talk about at another meeting like this. But short of that, if your lungs are severely damaged but not too severely damaged, could you provide new cells? Just like, paralyzed patients, can you provide new nerve cells so they can walk again and so on? Well, none of this has been established, and it's very much its infancy. And the National Cystic Fibrosis Foundation, which I find to be an extremely good authority rather than full of biases, has a strong, and I think you can read that probably on the website, I suppose, the statement that we got, but there's an encouragement that not only is it not proven, but if people are going and seeking this kind of therapy, it can be very dangerous, and it's also extremely expensive. I guess people are spending tons of money on this. So just a warning from the National Cystic Fibrosis Foundation, but they also said, this is not out of the question, that this would be someday a useful treatment. Maybe the puzzle of stem cell treatment for damaged lung cells will someday be solved, but it's not here yet, and so that's it. Any questions at all about anything I've said? Okay, so I just have one last thing I wanted to say, and I don't even know exactly what I want to say about this, but I've been sort of dying for the opportunity for a couple of years, and this is a good opportunity, about EPIC and our electronic medical records. And I think most of you have seen me swear at my computer, and so, but we understand that you are very frustrated by our electronic medical records, and I think probably a lot of you understand that we are very frustrated. And I think things will get better, but this is a brave new world that we've entered. And just to say a couple of things, and this was not a choice that certainly that we made. And to some extent, it's not even a choice that Providence made. We have our specific electronic medical record, which I find extremely complicated. There are various, there's several electronic medical records that are available, all of which are complicated, and I've only used two of them. But EPIC certainly is much more complicated than the other. And there's a good and a bad about the complication. The reason it's complicated is there's so many different things you can do in it that you can't do with a less flexible system. But it's so complicated it's difficult to use, and it's time-consuming, and this is just part of medical care. And no matter where you go, whether you have CF or whether you have a heart attack and you go in the emergency room, this is just what our country, and I guess the world, but particularly our country, from a political and financial viewpoint, has chosen. And we're all kind of struggling with it, and we apologize that it's been difficult for us. And I know that it feels very different when you come into a visit, and those of you who've been with the clinic for a while remember the good old black notebooks, which still are there, and you can just set it out, look at it, and flip through it, and talk to the patients, and so on. And I really like those old notebooks. And now we're kind of monkeying with our computer all the time, and we're getting better at it. But there are certain limitations. We're always going to be monkeying with our computers. And that's only the start of the story. That some other things that are going on. And again, this is a whole national system. So if you have complaints about it, if you have some specific complaints about, by the way, that we could possibly change a little bit to make your clinic experience a little bit better, let us know. I'm happy to hear about it. But to a great extent, if there are complaints about this whole gigantic system of electronic medical records, you need to complain to Rebecca. No, you need to complain to really, literally, to the government, because it's out of all of our hands. And it's not just some of the stuff that we're doing when we're clicking, and you're there, has to do with, how do I explain this in 2 minutes? the government basically is running out of money to pay for medical care. And they are trying to control costs, which is very important and very admirable. But one of the ways, I think the major way that they're trying to control costs is by denying payment to hospital or whatever if things are not exactly right in the documentation of the visit to the clinic, to the ER, to the history of physical, as we put patients in the hospital, and so on and so forth. So, and it's constantly getting more and more complicated. So in addition to having typing difficulties, in addition to not knowing exactly where to look for your last culture, we're also clicking in and out and trying to put down more and more and more and more, and more words because we're being demanded to do so, or Providence isn't going to get paid, or clinic will shut, or they will see. I mean, that's a very oversimplistic view of it. But this is an ongoing thing that I think is going to be debated and changed and fine-tuned for forever. I don't know how long it's going to come on. But that's my view, and I hope you don't mind my indulging me for giving you my view of a big change that's occurred in our clinic. And I don't think you can underestimate. You can't say, well, just that's a little bit of a change that's occurred, and they don't have black notebooks anymore. But it's been difficult for all of us, but I'm sure it's been very, very difficult for you. Okay, so that's the end. And any questions or comments or arguments or anything like that? Yes?
Speaking of the cost, what are they doing to address the cost of the drug?
I'm not sure. I'm the best. I bet Rebecca's a better person to answer that than I. Do you feel comfortable?
Sure, yeah. I mean, to address the cost of the drug, what the CF Foundation is doing, and they really fund like almost all of the medical research that's going on for CF, is invest in competition. So they're hoping soon that, like Dr. McCarthy described, there's Glyco is a first-generation drug, and by investing in competition, we're really hoping that a lot of pharmaceutical companies come to the market and bring a competitor to market. And that, we live in this free market, and right now we don't have any like government regulation on how much can be charged for a prescription. And like I mentioned, with such a small group of patients, I mean, even when we have a drug that addresses 50% of our population, that's still relatively small group of patients when you compare it to something like heart disease or cancer. So really just invest, not putting all of our eggs in one basket, and it's a very real scenario that other drug companies will be coming to the market within the next 5 to 10 years with competitors for Glyco, and that's what's ultimately going to provide some price controls.
Thank you. Other questions? All right, it could be lunchtime. You have to say anything more? I mean, you have to say anything?
I will say that one thing, and not only the support for having events, providing educational materials, amongst other things, but the companies that we have that are in the CF world, that are, most of them are represented today. Again, we thank you. They are very committed, and some of these are humongous companies. Abbott, and some of these, Hillrom, you'll see, beds in the hospital. But the parts of them that are kind of CF specific are extremely helpful in the CF community, not only for the things they provide that are just kind of tangible books and fun things, but they also really do a good job at helping in patient assistance. And so I know all of you have probably talked, we've talked about patient assistance programs for all the different companies, but when you're coming down to some of these high-priced drugs, and right now, Vertex is the only one right now on the market, but they do have some great programs, and so I think that these companies are committed to also make sure that you have access. But advocacy is also very important, so we can make sure everyone gets what they need when the doctor prescribes it. So it is lunchtime, so we have about a half hour, so feel free to grab lunch, visit the vendor tables, and then I'll kind of do the sirens and bring you back for our next speaker.